Greetings and welcome to a post-acute COVID-19 exercise and rehabilitation project program. The title of this program is Vital Signs, Oxygen, and Exercise Prescription. How are these impacted by COVID-19? My name is Hillegass. I'm a board-certified cardiovascular and pulmonary clinical specialist. I'm also the president and CEO of PT Cardiopulmonary Educators, and I'm an adjunct faculty at Mercer University, Atlanta, Georgia. I am here presenting today as part of the PACER project, and I am extremely honored to have been invited by both the Cardiovascular and Pulmonary section and the Acute Care Academy. I do need to disclose that I am the president of a web-based education company that provides continuing education for PTs and PTAs. However, today, this content is being provided pro bono for the Cardiovascular and Pulmonary section. This course is intended for educational purposes and does not replace mentorship or consultation with more experienced cardiopulmonary or acute care colleagues. You may require mentorship or consultation following this program or other ones. This content is also current at the time of this presentation. However, you must realize that evidence and science on COVID-19 is changing daily, and this information is subject to change. What I plan to discuss today is to present to you the normal and abnormal heart rate, blood pressure, SpO2 responses to exercise, and to be able to help you differentiate between a normal and an abnormal response to exercise. We're also going to be talking about oxygen delivery systems and discuss the amount of oxygen that you might provide and might find helpful for your patients. I'm going to briefly talk a little bit about oxygen and the long-term trials that have been in existence since the late 1980s. I'm going to talk about some legal implications of titrating oxygen. And then we're going to actually present to you information on exercise prescription and discuss case studies. And in this case studies, we'll talk about utilizing oxygen, the principles of oxygen, and vital sign responses to activities. So let's start with normal and abnormal responses to exercise first. Normal heart rate responses to activity are that your heart rate increases with increasing workload. And the rise in the heart rate is actually linearly increasing up to submaximal work. Once you reach submaximal or anaerobic threshold, your heart rate will then rise a lot faster towards your maximal. Heart rate actually increases about 8 to 12 beats per minute per MET of activity of the work. What is a MET? If you look down below at the bottom, one MET is the oxygen consumption at rest, which is actually about 3.5 milliliters of oxygen per kilogram of body weight per minute. And that's when you're sitting at rest. 2 METs is actually double what 1 MET is. And a 2 MET activity is pretty much walking, doing easy ADLs, a lot of things that we do in an acute care situation where we're not working our patients too hard. 3 METs is actually triple. It's equal to walking up a flight of stairs. So basically what we're going to be talking about is developing exercise programs for patients at about the 1 to 3 MET level, and not a lot further. Because what we're talking about is developing exercise programs for people after a severe critical illness. And they often cannot do high intensity exercise for the first 6 to 8 weeks. And so for the first 6 to 8 weeks, we want to get them up to their level of where they probably were before this virus hit them, as well as to help get them doing their activities of daily living. After 6 to 8 weeks, then we might be thinking about doing a much higher level of intensity with these patients. So the normal heart rate response to activity is a rise linearly to submaximal work. a rise of about 8 to 12 beats per minute per MET. And we know this rise in heart rate is greater with upper extremity work than lower extremity work. We know the rise is greater also during dynamic work versus isometric or static work. So that's very important to understand. The heart rate is also linearly related to oxygen consumption. So on this picture here, what you see is a couple of lines. So you see an A, a B, and a C. So A is your typical sedentary individual. Their heart rate rise is a lot higher than B, a trained individual, an individual who exercises regularly and tends to have higher max VO2s, oxygen consumption, maximal oxygen consumption, and also demonstrates a slower rate of rise in their heart rate compared to a sedentary individual, the red line A, who has a lower max VO2, but a much more rapid rate of rise in their heart rate because they do not have an efficient stroke volume that you can develop as a result of regular exercise training. However, on this slide, I've added a little line C, which is probably more the type of heart rate response we will see in our COVID patients. Our COVID patients have severe endurance problems, strength problems, and maximal capacity problems. And so we're going to see a much higher rate of rise in the heart rate, as you see here, and a much less max VO2 because they're severely impaired after this virus. And so you might see a much more higher rate of rise in heart rate than you do in an untrained individual. So that's one of the things you want to start getting prepared for, is the abnormal heart rate response that you would see in COVID patients. So let's go back to talking about normal again. Normal going from sitting to standing to walking across the room. When you go from sitting to walking across the room, you're basically going from 1 MET to a 2 MET activity. So your heart rate should rise about 8 to 12 beats per minute. So if I started at 70, at sitting, I should get to about 78 to 82 walking across the room. Now we know that's supposed to be normal for an individual. And we know that we see a lot higher rates of rises in our patients who have comorbidities, who have diseases and problems. So normal for an individual who doesn't have comorbidities and who also hasn't just recuperated from the virus. If we go up a flight of stairs, which is going from 1 MET to about 3 METs, then we're talking about a heart rate rise going from, if we started at 70, we would expect it to go up to maybe 86 or 90. So we would expect a higher heart rate of rise depending on the workload. If we're doing arm exercise, we might see a higher rate of rise than going up a flight of stairs, depending on whether our individual is trained doing their upper extremities or not. During isometric exercise, we would see less of a rise because that's an isometric static exercise versus a dynamic exercise. If we go from supine to sit to standing, and we've been on bed rest for a while, we might see a higher rate of rise going from supine to sit to standing to compensate for a drop in blood pressure if we have an orthostatic hypotension situation. So it's very important to also be measuring blood pressure when you measure heart rate, but we will get into blood pressure shortly. So therefore, if these are normal responses, then you should be able to differentiate normal from abnormal. You should be able to figure out abnormal heart rate responses and then figure out what does it mean. Most often when we see a much more rapid rate of rise, we're talking about an individual who has less of a stroke volume that can help with the activity. They may have much more endurance impairments, or they may have other impairments. So we want to note what a normal heart rate response is and compare that to what we find in our patient. If we determine abnormal in our patient, we need to compare it to the other vital signs and then make a clinical decision based upon that. Heart rate response can be affected by disease, by inactivity, and by medications. And we're going to talk about the medications particularly that affect our heart rate. Beta blockers are probably the number one that we see that will affect our heart rate. That'll block your heart rate response and actually blunt it, so you'll see a much lower rate of rise. Beta adrenergics on the other side might raise your heart rate response because they're actually stimulating beta 1 receptors, which could increase their heart rate response. Fever can make a difference in our heart rate response. Low blood volume can make a difference in our heart rate response. And so we do know that we may see, our patients may have had fever, they may have had low blood volume, or they may have low volume when they go home and maybe they're dehydrated. So we do need to consider all sorts of factors with our patients. So let's refresh our abnormal heart rate responses. Rapid rate of rise, such as seen in deconditioned individuals or those who have an inefficient stroke volume. A very slow rate of rise that's blunted and they're not on medications. That's a very abnormal response. So if they're on beta blockers, we would expect to see this blunted response. But if it's blunted and they're not on beta blockers, that might be of concern. If their heart rate decreases with increased work, that's very abnormal, and that's also very rare. But we have seen this type of response, and when we tend to see this kind of abnormal response of a decrease, it's usually because the patient is throwing many more arrhythmias, possibly premature ventricular contractions. So with arrhythmias, we might see a decrease with increased work. That's an abnormal response. That would be an indication, A, to manually be palpating that pulse, and B, hopefully getting some kind of ECG to assess, are they having arrhythmias? If we're palpating the pulse, we should also be assessing for regularity. It's normal for you to have a regular rhythm, but we have many patients that have irregular rhythms due to arrhythmias. Regularly irregular might be every third or fourth or fifth. We palpate a little pause in the pulse. But irregular is the type of rhythm we typically palpate with someone who has atrial fibrillation. So we do want to palpate the pulse, not just measure it with a pulse oximeter when we're working with our patients, because we also want to see regularity of the heartbeat. So this program is based on trying to help you understand responses and develop exercise prescription for patients who've just gotten over the coronavirus from the hospital. And we're talking about patients who have been very, very, very sick. So what we would expect to see as heart rate responses in these patients would be a rapid rise in their heart rate. We also would expect to see a very poor tolerance, very quick fatigue, and a very low maximal performance. And why is this? That's because these individuals have very poor endurance. This virus has truly affected not only their lungs, but the rest of their body. They may also be actually having difficulty with oxygen diffusion into the circulatory system. And so with their exercise, they may actually have a rapid heart rate rise because their oxygen saturation is decreasing with activity due to the inability to diffuse the oxygen into the circulatory system from the virus and its effects on the lungs. If this is happening, we should also be seeing a respiratory rate that's also increasing. So what's the bottom line here? We should not only be checking the heart rate, but we should be looking at the oxygen saturation. Very, very, very important. All right, let's talk about medications that can affect heart rate and blood pressure responses. One of the things you need to remember is that with the COVID virus, that this virus tended to affect individuals who had comorbidities much more severely. And those comorbidities that have been correlated with a much more severe COVID response is obesity, diabetes, cardiovascular disease, including heart failure, and COPD. Also, individuals who are immunosuppressed. So patients with these comorbidities are often on medications to control their symptoms and the manifestations of the disease. And that includes drugs like bronchodilators for COPD or asthma, antihypertensives for patients with cardiovascular disease and heart failure. And those include ACE inhibitors and ARBs. Could also be calcium channel blockers. They could also be on diuretics. They could be on beta blockers. They could be on insulin. And some of these medications that I've just listed do affect heart rate and blood pressure responses. So we need to be looking at all the medications our patients are taking, but particularly to identify those that would affect heart rate, blood pressure responses. And the number one type of drug that affects heart rate and blood pressure responses are the beta blockers. Beta blockers are in wide use in America. They're used for managing hypertension. They're used for managing angina by lowering the workload on the heart, by lowering the heart rate and blood pressure, which decreases the myocardial oxygen consumption. They're also used in patients post-MI, post-stent, and post-CABG to lower the workload on the heart. And there's a tremendous amount of evidence that shows that beta blockers actually improve morbidity and mortality post-MI or CABG, and also decrease the abnormal ventricular remodeling that can occur with injury to the heart muscle. So they're used widely for a lot of different cardiovascular issues. And therefore, many of our patients that we see post-COVID may be on beta blockers. So we need to really understand beta blockers. Now, beta blockers actually work primarily on the heart, although they do have impact on other systems. But we want to concentrate today more on the effect on the heart. So how do they work? The beta blockers actually block at the sympathetic chains, not the parasympathetic, but the sympathetic chains. So we have sympathetic nerves, vagi, go into our heart, and they actually increase parasympathetic, slows the heart, because the receptors are at the SA node and the AV node. Sympathetic chains are also at the SA node and the AV node. And if you can see, there are sympathetic chains also throughout the cardiac muscle. So sympathetic innervation to the heart will increase the heart rate, increase the conduction velocity through the heart, and increase the force of contraction by all these receptors that are in the muscle. And so you get a stronger force of contraction, as well as an increased heart rate and an increased conduction throughout the heart. So if sympathetic does that, and beta blockers block sympathetic input at these receptors, then what happens is you will have less of a heart rate at rest, so a lower resting heart rate, lower conduction velocity, less of a force of contraction with stimulation from the sympathetic chains because they're being blocked. So you'll have a lower heart rate rise with activity. You'll have less of a blood pressure rise with activity. And that's very, very important to understand. So if they're on beta blockers, we cannot utilize mathematical formulas to figure out a person's maximal heart rate or target heart rate or whatever, because we aren't seeing an actual heart rate response. We're seeing a beta blocked heart rate response. So beta blockers lower the heart rate, they lower the systolic blood pressure. They also actually decrease the contractility of the myocardium somewhat, because remember, they do have receptors in the muscle. But beta blockers do have an ability to limit that abnormal remodeling, and it can prevent that early ventricular dilatation after cardiac injury. So there's a lot of reasons why beta blockers are used, even though it may affect our heart rate response with activity. Your patients who are taking beta blockers can have some side effects, and one of the number one side effects is they feel more tired. They feel weaker. They have trouble sleeping sometimes. They may have some depression, memory loss, impotence, hypotension. They may have overflow to the beta 2 receptors in the lungs and have some mild bronchospasm, and probably bradycardia, a lower heart rate than others. So what are these beta blockers? These are ones you should know. They have an OL at the very end. Carvedilol, carvedilol, labetalol, nadolol, pindolol, etc., propranolol. So some of your more common ones that you will see carvedilol. It's called Coreg, that'll be listed, or you might see a lot of Toprol that's used across the country. Many of these others are used across the country, but Coreg and Toprol might be the more common ones that you would see. So get to know your beta blockers and understand that they actually block the heart rate rise. So when they're on beta blockers, they look like they're a trained individual when they're not. Beta blockers will also affect blood pressure response. So as we talk about blood pressures, keep that in mind, that if they're on these beta blockers, they'll have a slower blood pressure rise with activity. All right, let's turn to blood pressure responses. So what is a normal blood pressure response to activity? Well, your systolic and your diastolic have different responses. Your systolic is your top number, your ejection pressure from your heart. And your systolic pressure should go up gradually with activity, whereas your diastolic blood pressure should stay fairly the same as at rest. It should say plus or minus 10 millimeters. So your systolic blood pressure increases similar to your heart rate rise with activity, but your diastolic blood pressure should pretty much stay the same. And just like in heart rate, your systolic blood pressure should increase 8 to 12 millimeters of mercury per minute of activity work. So again, a very gradual rate of rise. The response is greater when we do upper extremity work, because upper extremity work is harder. We have smaller muscles, less muscle mass, more resistance to flow, and more against gravity movement compared to the lower extremity. We also have greater rises in your blood pressure when we do static exercise, which is the opposite of what we said for heart rate. Heart rate rises much more with dynamic, blood pressure rises much more with isometric. So if they're gripping or they're lifting a heavy weight, we might see a higher rate of rise. The diastolic blood pressure, however, should remain unchanged. It may actually decrease with aerobic activity due to all the vasodilation that occurs with activity. And we may see a diastolic blood pressure increase with heavy resistive activity, okay, or static activity. So those are your normal responses. So what are your abnormal responses? Your abnormal responses, again, like heart rate, would be a rapid increase in the systolic blood pressure. Or an individual who's not on a beta blocker, we see a very blunted or slow rise in the blood pressure. An extremely abnormal blood pressure response would be to see a drop in the systolic blood pressure while exercising. So increasing exercise, we shouldn't see a 10 millimeter or more drop in the blood pressure. The diastolic blood pressure, as we said, should stay plus or minus 10 millimeters. And one of the most abnormal responses is when we see a progressive rise in the diastolic pressure. Not when they're doing exertional exercise, but when they're doing any other kind of exercise, particularly aerobic. That would be an abnormal response and possibly an indication that they're having resistance to blood flow in the heart, which would mean increased blockages in the coronary arteries. So that's an abnormal response that we see, particularly in individuals who may have atherosclerotic plaques throughout their coronary arteries. So now let's talk about a normal blood pressure response with all sorts of activities. When we go from sitting to standing to walking across the room, we should not see orthostatic or dropping in blood pressure, and we should see an increase from going from 1 met to 2 mets. So we should see an increase in our systolic blood pressure, 8 to 12 millimeters of mercury. So go from 120 to maybe 130 or 132. And diastolic should stay the same. So 120 over 80. 80 should stay similar, maybe 80 to 86 or 80 to 76. But plus or minus 10 change for diastolic, and systolic should go up about 8 to 12 millimeters of mercury. So if they go from sitting to standing to walking across the room, they started at 120 over 80 and they just walk across the room and they go to 160 over 80, that would be a very rapid rise. If they go up a flight of stairs, which we said is about 3 METs, then they should go from 120 to maybe 140, 135, 136 to 140 because it's a higher workload. Again, the diastolic should stay the same, plus or minus 10. When they do arm exercise, they may again go up higher than 8 to 12 millimeters of mercury per MET. And so you might see them go from 120 over 80 to 140 or 150 over 80 doing arm exercise. Doing isometric exercise, again, much greater rise with an isometric exercise. And with isometric exercise, we might see a greater rise in diastolic pressure. If they're going from supine to sit to stand and they've been on bed rest for a while, their systolic blood pressure might drop. Because of going against gravity, they become orthostatic. When their blood pressure drops due to orthostasis, their heart rate will rise. So one thing to try and overcome some of this orthostasis is to have an individual try and do some upper extremity work, which really raises their blood pressure, to see if they can maintain the upright. So again, you must look at all these different situations and check their heart rate and their blood pressure responses to all these activities against gravity, with isometric, with arm, with higher MET activity. All these things are things we should be assessing. And then again, you're supposed to be comparing and contrasting. Is this a normal response or is this an abnormal? Is this an abnormal that I can work with, or is this an abnormal that I need to contact somebody because it's very abnormal? Now, what I said is that most of our patients that we're going to be seeing are either post being on the ventilator in the acute care setting, or post being very sick in the acute care setting, to maybe in the outpatient setting or at the home, we might be seeing these people and they're not very active. So even though they're in the home or coming into the outpatient setting, we should still rule out for any orthostatic hypotension. And it's very simple to do by assessing heart rate and blood pressure responses to postural changes. Have them see what their supine pressure is and their heart rate, sit them up and stand them up, and see if you see a greater than 10 millimeter drop in their systolic pressure with a rapid rise in heart rate and maybe complaining of dizziness. So it's important to identify these things, because if they are orthostatic, they're at a higher risk of falls, and we don't want that to happen to these patients either. Keep in mind, these are patients who have comorbidities, or they wouldn't have been as severely ill with the disease. Often individuals who have comorbidities are taking additional medications, and those medications can affect their blood pressure. Vasodilators, nitrates, ACE inhibitors, ARBs, calcium channel blockers. All of these can affect their blood pressure. So make sure you know what medications they're taking, and please look at these patients to see if they have orthostatic hypotension. Now, if you're unfamiliar or still get confused about the difference between orthostatic hypotension and exertional hypotension, I've given you a resource here that was recently published by 2 authors in the Journal of Acute Care PT. They looked at the difference between orthostatic hypotension and exertional hypotension and talked about what it is, what causes it, and what's the treatment. But briefly, orthostatic is when you go against gravity and you have drops in systolic blood pressures with rises in heart rates. Exertional is when your blood pressure drops with activity, not with standing up, but when you're walking, the blood pressure drops. That's different. That means that your cardiac output is dropping, that your stroke volume is not able to handle the workload. So exertional hypotension may mean that they have a comorbidity that you're dealing with, and it's a pump dysfunction. So that would be something that can't be overcome with trying to get them upright much more. Exertional hypotension may mean that you need to give a call in to the doctor and say they can't handle the activity they're doing. They're having an abnormal systolic blood pressure response to the activity you're doing, not the overcoming gravity activity. All right, the third vital sign we want to monitor is the oxygen saturation. And that's really critical with these patients. They may not have had a thorough evaluation in the hospital if you're seeing them in the home or in the outpatient setting. Or you may be seeing them in the hospital. You want to be checking their oxygen saturation with activity. The reason is this disease truly affects their whole lung, all the alveoli, and it affects their diffusion. So the normal response is that we're able to diffuse oxygen into our circulatory system, and we have no change in oxygen saturation. A minimal decrease or a minimal increase with activity would be a normal response. An abnormal response is when we're increasing our activity. If we can't diffuse the oxygen fast enough to get into the circulatory system to meet the needs of the activity, then we'll see a drop in the oxygen saturation. It's particularly significant if it drops greater than 90 or greater than 4 percentage points. So they start at 96 and even drop to 92, that's very significant. When they drop, when the SpO2 drops, you should be seeing a rise in heart rate and a rise in respiratory rate, because that would mean that they're trying to get more oxygen in when the oxygen saturation is decreasing. And if the SpO2 is dropping below 88 or more than that, then we need to be very concerned. So respiratory rate should correspond with heart rate changes. And respiratory rate will actually severely change when the SpO2 is dropping, when the oxygen saturation is actually dropping in the blood. Heart rate will also severely rise when there's a drop in SpO2. We also need to be concerned when we're working with our patients if they have too high of a respiratory rate at rest. So what's the normal oxygen saturation response to getting up, sitting, standing, and walking across the room? Again, it should stay the same. Minimal increase, minimal decrease. Minimal being like 1, percentage point. Going up a flight of stairs, it should stay the same. Doing arm exercise, it should stay the same. But keep in mind, if the O2 sat monitor is on the arm where you're doing the arm exercise, that could make it change. So that could interfere with a good reading. So do the arm exercise and then immediately put the O2 sat back on to measure, because the arm exercise with the O2 sat monitor on it is going to be not very accurate. Isometric exercise, if they're gripping a walker and they have that O2 sat monitor on, it's not going to be accurate. Take that arm off, let them not be doing gripping, and you might get a more accurate reading. Going from supine to sit to stand, their O2 sat should stay the same, even if they've been on bed rest. If it drops, then you've got to look to see, is there a heart rate rise and is there a respiratory rate rise? If there isn't a heart rate rise and there isn't a respiratory rate rise, but the SpO2 drops, yes, that's abnormal, but that's abnormal because it's not a physiological response. It's a problem with the O2 sat monitor. It's either that the patient was moving, they're not having good contact. Remember, we're measuring peripherally and externally and not internally. So do not make your clinical decision based on an O2 sat dropping and a respiratory rate and heart rate not changing at all. That is not a problem physiologically. That's a problem with the O2 sat monitor. As I said, abnormal SpO2 responses are a drop in SpO2 with any activity. If that SpO2 drops, the heart rate should go up. Respiratory rate should go up. If the SpO2 drops and the heart rate does not change and the respiratory rate does not change, do not believe the oxygen sat pulse oximeter. Put it on another finger. Okay? If the O2 sat drops and the heart rate does increase and the respiratory rate does increase, what should you do? Well, all of you are going to say sit them down. And if they don't have oxygen and they don't have an order for oxygen, then that's the answer. But if they do have supplemental oxygen, then they have the order for supplemental oxygen, then we should be titrating the oxygen up. So we'll talk about that when we talk about oxygen. All right, so we also need to assess symptoms with activity. So we've talked about heart rate, blood pressure, and SpO2. We need to assess symptoms with activity. So what are symptoms with activity? With these COVID patients, we're looking at either fatigue or dyspnea. And there's 3 different scales that you can use. This is the original Borg scale that was used for perceived exertion, 6 to 20. And around 13, somewhat hard, is where we're starting to get into anaerobic work. So most of your patients you want to keep at 13 or below. There are 2 0 to 10 scales. There's the modified VAS and the modified Borg. If you look at them, you'll see, particularly when you get to moderate is around 5 on the modified VAS, and on the modified Borg, moderate is 3. So you will see a difference in these 2 scales. All I have to say is choose one that you feel comfortable using, that your patients understand, and use that, whether it be the Borg scale 6 to 20 or one of these 0 to 10s. You will hear me talk about dyspnea when I do a 6-minute walk. I primarily use the modified VAS, just my comfort level. So all of these scales have numbers that are related to moderate and moderate to severe. This is where the patient should be working. They should not be working in the severe ranges. They're impaired, they have dysfunction. We don't need to be working them that hard yet. Above moderate to severe, they're working anaerobically, and that's not really efficient early on in rehab, especially in the early recovery. All right, so a way to review is to give you some examples. So we have a patient, they're supine, their heart rate 72, blood pressure is 124/78, SpO2 is 96, and they're tired. You sit them up, their heart rate goes to 84, their blood pressure goes to 110/70, their SpO2 goes to 94, they say they're tired. You say, okay, there was a drop in blood pressure, a rise in heart rate, a drop in SpO2, but they're still doing okay. Let me see what happens when I do some arm exercise while they're sitting. Let them sit there a little longer and do something. So they do an activity while they're sitting, their heart rate goes up, their blood pressure goes up, SpO2 stays the same. Okay, so again, they're responding well to activity. So let's stand them up. Heart rate goes up to 108, blood pressure drops to 94/68, SpO2 a little drop, and they complain of shortness of breath and lightheadedness. So what do? Well, if they're only mildly short of breath, you might want to try and keep them in standing. So you might have them do some kind of marching in place, or an upper extremity using their arms raises their pressure. If they're doing okay, you can continue to move them. When you go and you ambulate, you find that their heart rate goes up, and what their blood pressure do? It went up, so it was a normal response. So what's the interpretation of these vital sign responses to activity? They had a drop with sitting and a drop with standing of blood pressure. They had a normal response to ADLs, and they had a normal response to ambulation. So their problem is orthostatic hypotension, not exertional hypotension. So they need to work on being upright more, maybe more fluid volume as well, because that may be a problem. but they're not a problem with exercise. They had normal responses with exercise. They don't tolerate exercise very well because they could only go 6 feet with ambulation. All right, next patient. Patient has an irregular heartbeat. They have AFib. They have 80 at rest, 118/72, SpO2 96. They sit up, their heart rate goes to 90, their blood pressure goes up a little bit, their SpO2 stays the same. So while sitting, you try them and their heart rate, you do an ADL activity with sitting, having them do some arm work. Heart rate goes up, blood pressure goes up, SpO2 stays the same. Okay, no contraindication of mobility, let's keep going. Stand them up, heart rate stays the same, blood pressure drops a little bit. They say they're tired, but no real abnormalities here, a minor drop in the blood pressure. So you start them walking. Their heart rate goes up, and what happens with walking? Blood pressure drops, SpO2 drops, and they complain of shortness of breath and fatigue. So what do you have here? Supine to sit was normal. Sit to stand was a little bit of a drop, but the stand to walk was a drop. So this person's demonstrating very minimal drop with orthostatic, but their problem is they're symptomatic and a blood pressure drop with ambulation. That's exertional hypotension, okay? If you continue to see that on the second time you do them with exercise, then I would be contacting the physician. That's telling you with activity, their blood pressure doesn't tolerate the activity. So that's an abnormal exertional hypotension. All right, third patient, supine 100, blood pressure 120/76, SpO2 93, they're short of breath. Sit them up, heart rate goes up, blood pressure goes up a little bit, SpO2 drops a teeny bit, no big difference in shortness of breath. Okay, while they're sitting there, we do an ADL. Heart rate goes up, blood pressure goes up, SpO2 drops. And they complain of increased shortness of breath. All right, we let them rest a little bit. We stand them up. Heart rate goes up from sitting, 106 to 110. Blood pressure drops a little bit from sitting, 124 to 120. SpO2 dropped a little bit, 92 to 91, but they're still above 90. So I'm feeling, okay, let's see what happens with walking. They walk 10 feet. Heart rate goes up, normal response. Blood pressure goes up, normal response. SpO2 dropped. So what do we have here? With ADL and with ambulation, with activity, their SpO2 is dropping and their heart rate's going up. So we have a situation that they're desaturating with activity. That's an abnormal response. Now, if we don't have oxygen and we don't have an order for oxygen, we have to stop every time they get so short of breath and that SpO2 drops so much. So it's oxygen that's limiting them. So this type of patient would benefit from supplemental oxygen with exercise. Why I point this out is this may be what you see with your COVID patients. No one really checked to see their SpO2 drops with activity, so they were not sent home with oxygen, and they may benefit from oxygen. Otherwise, you have to stop every time their SpO2 drops because they're symptomatic. So you're being limited, and they're being limited by oxygen. If oxygen could improve their exercise, they could get better faster if they had supplemental oxygen. So this might require a conversation with the physician. So why are you going to see abnormal responses with patients who've had COVID-19? They've lost skeletal muscle from bed rest, but particularly aerobic muscle fiber loss. And now their muscles are more inefficient at extracting oxygen and there's less skeletal muscle. They have less of the enzymes, etc. They have endurance impairments because they don't have aerobic muscle and aerobic fibers. They can't do the distance, okay? And then they also have diffusion impairments from the disease. Diffusion is decreased. Therefore, less oxygen is getting into the system for energy. On the left of this diagram, you have a normal alveoli, very thin alveoli to capillary interface. On the right, you have a result of having injury to the alveoli from this ARDS-like disease that causes, after the disease, inflammatory, fibrotic type situation around the alveoli, which makes it thicker membrane, harder to diffuse oxygen from the alveoli into the capillary. So instead of going through a thin film, this oxygen is now trying to go through jello, thick jello, to try and get into the capillary. So diffusion is maybe okay at rest, but when you need to diffuse faster to meet the demands of the exercise, you're getting less oxygen into the system because of this thickness that it has to diffuse through. So very important to understand this concept, that they have aerobic muscle fiber loss, they therefore have endurance impairments, and they may have diffusion impairments that are not being picked up at rest. So you may be the one picking this up with exercise, that you need to be making the call to the physician. So what abnormal responses are you going to see in patients who've had COVID? A rapid heart rate rise if they're not on beta blockers. Rapid blood pressure rises to activity. They're going to be symptomatic, and they're going to reach moderate to severe dyspnea early on in their activity. So we've got to keep them at the moderate level. You may see decreases in SpO2 with activity. And when you see the SpO2 dropping, you should be seeing a rise in heart rate and a rise in respiratory rate. So these are the abnormal responses you're going to see, and you've got to make the clinical decisions of what to do based on these abnormal responses. Now, my goal was not to teach you about outcomes, but I do want to talk about a couple of outcomes you should be measuring, and you should be measuring vital sign responses in these outcome measures. You should measure some sort of exercise tolerance with these patients, typically either a 6-minute walk, you could do a 2-minute step test, or you could do a gait speed test. The 6-minute walk is a measure of endurance, and you don't have to have your patients walk the entire 6 minutes. They may need to stop, lean against the wall, or sit down. It's your stopwatch that runs for 6 minutes. Your job is to measure how far they walk in the 6 minutes. Not that they walk 6 minutes, but how far. Safety's key. Monitoring heart rate, SpO2, and symptoms is key. Here's an example of an outpatient 6-minute walk. And you can see what right here around minute 2, they already dropped their SpO2 to 83, heart rate jumped up, and dyspnea is going up. They go another minute, SpO2 drops a little more, heart rate's going up. Now their dyspnea is getting worse. Here's their SpO2 dropping to an all-time low of 78, and they stopped because they got to a 9 out of 10 dyspnea. Let them rest. They bounced back up a little bit, not a lot, but they could walk a little bit, okay? And then they walked like a half a minute left, and they got to a high of a 6. They'd been at a 9, and then post-exercise, you watch them recuperate. So you can see this abnormality. This gives you documentation to show the physician that this patient definitely needs oxygen with activity. There's also evidence on 6-minute walk distances. The less you do, the more impaired you are. An average for a healthy male who's in his 60s or more would be 1,700 feet, 1,500 for females. So your patient walks 200 feet in 6 minutes. Can you say they're severely endurance impaired? Yes. And the minimal clinically important difference between 2 walk distance tests, so before you start intervening and after you start intervening, is 14 to 20 meters. Now, I also mentioned the 2-minute step test. Not here to tell you how to do them all, but just to briefly tell you about them. It's when you raise each knee to a midpoint between the iliac crest and the patella. They do this for 2 minutes back and forth, and you score the number of times the right knee reaches the required height. There's normative data out there. Can you imagine this post-COVID patient has been on a ventilator, they're 60 years old, they come home, and you want them to do this 2-minute step test. If they do 67 of these, they're in the lowest percentile. Does that show you how impaired they are? So it's a great test to show endurance impairment as well. All right, and then the third test for exercise is gait speed. And actually gait speed is one of the components of the short physical performance battery, which I love because it shows you lower extremity function, which is also a severe problem we're seeing in COVID patients. COVID patients leaving the hospital are looking like the PICS patient, the post-intensive care patient, and they also look like they look like an interstitial lung disease patient, and they have problems with lower extremity function. So the SPPB includes the gait speed, which is an endurance test or an exercise tolerance test, and then also has a standing balance test and the chair rise test. The SPPB has chair rise, gait speed, and a balance that we'll go through. The gait speed is you measure their speed for 4 meters, click on when they cross over the 1 meter, click off your stopwatch when they cross over the 5 meter. And you can convert their meters per second to their seconds that they walk to their meters per second. And that can also be converted to miles per hour. So 4 seconds, if they did that, that's 1.0 meters per second. And that's equal to 2.2 miles an hour. Gait speed can be converted to function if you look at the Fritz and Lasardi paper, white paper. The walking speed, if you walk less than 0.6 meters per second, you're more dependent, more likely to be hospitalized, more risk for falls, be a household walker. 1.0 meters per second or greater, you're more independent in ADLs, less likely to be hospitalized. And if you fall between 0.6 and 1.0, then you're in that intermediate area. The chair rise test, they're not supposed to hold on with their arms. They're supposed to stand up with their arms crossed in front of them, and you count how many times they can get up and down. 5 times. You measure the time it takes them. And so for a 5 times chair rise, these are the average chair rise norms in individuals who've not had COVID. So you can compare your COVID patients' results to norms. And then the third test in the SPPB is a real quick balance screen. 2 feet together, no shoes on, side by side, semi-tandem, and tandem. They have to maintain each position for 10 seconds. So it's a nice balance screen. If your patient is more impaired, you're still in the hospital treating these COVID patients, you might consider some other types of outcome measures. You could do the 6 clicks, the AMPAC 6 clicks, or the Johns Hopkins Activity and Mobility Program, which is a 1 through 8 score. So hopefully by now you've learned something about vital signs that will help you with COVID. Hopefully it's more than a refresher and can help you with treating these patients. I now briefly wanted to talk about oxygen, and then I want to get into exercise prescription. So you do need to understand supplemental oxygen, that there is a history. And so because of the history, people have these horrible myths about oxygen. And it's a shame because oxygen, yes, it's a drug, but it doesn't hurt people. If it did, we all would have a problem because we all need oxygen. The problem is that there were 2 state-of-the-art research trials in the end of the 1980s. And what they found is that with oxygen given at night, survival was better if individuals used oxygen 12 to 15 hours per day, or if they used it continuously. They actually had better survival if they used it continuously in COPD patients who had chronic stable hypoxemia. They also showed that using nocturnal oxygen and continuous oxygen improved brain function. And that in the BMC trial, the improved survival was better with those who had it 15 hours a day compared to no oxygen at all. And these were for individuals who had PO2s less than 55. The one thing that came out of these trials is that you should not over-oxygenate patients who have COPD. And what they found is if they gave them too much oxygen at rest, these people had hypoventilation. That carried over to where people said, oh, you can't give these COPD patients too much oxygen, they'll hypoventilate. And they carried over the result of where it was patients hypoventilated when they were at rest with too much oxygen. They carried that statement over to everything. So that people believed that if you gave them too much oxygen with exercise, they would hypoventilate. And that's not true. The study only found at rest, not with activity. And when do we need oxygen? We need oxygen with activity to be utilized in the muscles to create energy. So the problem is they carried over the at rest part to all the time. Therefore, people became very afraid of using oxygen. Now, these studies were done on COPD patients. We are not talking about COPD patients with COVID, except if they had a comorbidity of COPD. With COVID, we're talking about a restrictive lung disease. As I just showed you, the inability to diffuse the oxygen through that thickened membrane of the alveolar surface into the capillary. That's the problem we're dealing with. And so when we can't diffuse fast enough, we should be giving them more oxygen to increase the gradient of pressure, not less oxygen. So there's no impairment, and these patients are not going to hypoventilate. This is not the same situation. They really need more oxygen. So we need to stop being afraid of oxygen, particularly in this population. We also need to realize that it is a drug, but there are no restrictions in physical therapy practice for use of oxygen with patients. We can't initiate oxygen except in an emergent situation without a prescription, but we can titrate oxygen. And titration is permitted because there's usually an order for keep SpO2 like greater than 90. Typically, you'll find this in the respiratory section of the chart on the admission orders. You'll find that same kind of prescription when they go to home health, when they go home and they have home health. The home health office typically has this order. You as the therapist may not have it in front of you, but the office actually usually has it. In the outpatient setting is the only place we typically don't have keep SpO2 greater than 90 unless you're in a pulmonary rehab program. So therefore, if you're in the outpatient setting, that's where you'd have to call the doctor. The other time you'd have to call the doctor would be if they don't have any oxygen and you've just done an exercise test or a vital sign assessment and you're finding that their SpO2 is dropping, their heart rate is rising, their respiratory rate is rising, and they can't do much exercise because of this situation. That's where you get on and you say to the doctor, we need to get exercise oxygen. We need to get oxygen prescription for exercise. And then you want the prescription to say, keep SpO2 greater than 90 or 88 or whatever, so that you have the permission to titrate. More information about oxygen can be found from these guidelines that were written in 2014 in the Cardiovascular and Pulmonary Section journal, the Journal of Cardiopulmonary Physical Therapy. And it explains not only the past history, but it also talks about all the different FDA requirements and also provides you an oxygen algorithm. So if you still don't understand oxygen, you do have a resource that you can use for titration. Now, we typically don't take arterial blood gases, but we do measure oxygen saturation. So it's very key to understand the relationship of oxygen saturation to the partial pressure of oxygen. And why do we say keep SpO2 greater than 90? Because if you look on this curve, if you go up to where the curve gets the steepest drop off, it's right where PO2 of 60 is. PO2 of 60 equals an SpO2 of 90. So if you go below 90, you're really falling down this roller coaster of a hill very fast. Where you aren't if you go above 90. So our goal is to keep SpO2 greater than 90, and then we know we have a better PO2 present in our capillary arterial system. So that's where we get the keep SpO2 greater than 90. The other things you need to know is that pulse oximetry is peripheral measurement. It's not indwelling. So there are problems with pulse oximetry measurement. There's blood flow. If they have a poor cardiac output and their fingers are freezing cold, then you're not going to pick up their pulse ox, their oxygen saturation from the pulse ox. You're going to need a different probe, maybe a head probe or an earlobe probe, because poor circulation doesn't reach the fingers, and that's where they're picking up the oxygen saturation. Irregular rhythm, nail polish, all these things can, and pressing hard on a walker or anything will affect pulse oximetry. You also need to understand how oxygen is given. There's two types of portable units. One provides continuous compressed gas, which is your big tanks, but it makes it very difficult to get around, particularly with a walker. Whereas the portable unit that you could carry is often given as pulsed oxygen delivery. So it's a psst, 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 where based on inhalation, inspiration, inhalation, the oxygen, the nasal cannula senses the inhalation pressure and will deliver a bolus of oxygen. So they may not do as well with activity with a pulsed oxygen delivery as they would with continuous. If you happen to have a portable unit that provides continuous, keep it on continuous when they're exercising. That would be a better, they get their oxygen a little bit more regular, and they tend to not drop as much in their SpO2 with the continuous versus the pulsed. Your patients, if they come home on oxygen, may have a portable oxygen concentrator, or they may have a home oxygen concentrator. You have to be careful with these home oxygen concentrators because usually these patients extend their tubing longer and longer and longer. We recommend no longer than 100 feet, or you actually start to lose the amount of oxygen that you're delivering because of the length of the tubing. And oxygen can be delivered in multiple ways, different masks, etc. It's important to know that of the different ways that it is given. So your nasal cannula is your low flow system. It does increase your oxygen concentration, but they have to breathe with their inhalation with their nose. So a nasal inspiration versus a mouth inspiration, and they'll get the oxygen. If they're using the nasal cannula and they're breathing through their mouth, then they're not going to get the benefit of the oxygen. The increase in the oxygen concentration is anywhere from 24 to 40%, and that is dependent upon the liters per minute that's given. So typically room air is about 20%. So it's each liter is about 4%. So 1 liter is 24%, 2 liters is actually 28% fraction of inspired oxygen, 3 liters 32, 4 liters 36, etc. Your nasal cannula is only to provide liters per minute of up to 6. Once you need to go beyond 6 liters, then they typically will have a high flow nasal cannula like this, which has a wider diameter, or that you may see the nasal pillows. You may see more of a system like this to provide high flow. And these can give you a lot more liters of oxygen per minute to help with that oxygen that's we're trying to get into the circulatory system. So high flow is best for people that need more than 6 liters, and it's more comfortable. You can eat, you can drink, and talk. If they're not sent on high flow and they need more than what actual nasal cannula can give them, they may also have an oximeter, which is a reservoir that holds oxygen, and there's 2 different types of oximeters. And that usually allows a patient to use less oxygen from their tank. It's a good way to deliver oxygen at home. So it's a supplemental type of oxygen reservoir that conserves oxygen. Another way that oxygen can be given is with a face mask. So if they're a mouth breather, this might be the best way to deliver the oxygen, particularly when they're sleeping and they're breathing through their mouth, or if they refuse to breathe through their nose when they have nasal cannula. The face mask gives anywhere from 35 to 55% FiO2 as far as that goes, and can also be connected to a tank for mobility. So it's very important to know that there are different ways to deliver oxygen. So what's the takeaway about oxygen? Patients with COVID-19 may have problems with diffusion. They therefore will demonstrate a drop in SpO2 with activity and a rise in heart rate and respiratory rate because they can't diffuse fast. It's very important to measure this with all activities. And if oxygen is limiting their activity and the patient has to stop due to dyspnea and a drop in SpO2 less than 90, we really need to take the next step and call the doctor or the PA. Obtain the order for oxygen with activity to improve their ability to perform activities. And it is, you have the legal ability to do that. You want to keep your order to say keep SpO2 greater than 90. They may have activities, they may have problems with activity, but they may not drop their SpO2 severely enough to need oxygen. So therefore they may need intermittent exercise, rest when they drop. If patients do have oxygen prescribed and they have oxygen at home, then you can titrate for all different activities based upon a legal order of keep SpO2 greater than whatever. So if you're doing home health, your home health agency should have that. If you're in the outpatient setting, you can get the verbal order for that from the physician or the PA or NP. So make sure you really understand and consider oxygen needs for these patients. And lastly, I would love to talk about exercise prescription. So now that you have their vital sign responses to activities, now is when you develop an exercise program for them that's safe. You want to develop an exercise program that's going to help them with strength deficits. You want to help them have an exercise program that helps them with endurance deficits, and one that also helps with breathing and oxygen deficits. You need to consider the components of an exercise prescription: mode, intensity, frequency, and duration for all activities, whether it's strength or whether it's endurance. Intensity is the hardest to determine, but I've given you tools. You can use RPE, you can use the 0 to 10 BAS scale, the 0 to 10 Borg scale. You can use a target heart rate. So on their exercise that you had them do, what's the highest heart rate they got to? That could be the way that we use an intensity. Or where they just get to SpO2 of 90 and they don't go below it. That would be your intensity. Duration, you may be doing 1 or 2 minute bouts in the beginning, and you want to build up to 30 minutes of continuous. But you may be starting with lots of bouts and then rests in between. And you build up the number of bouts with rests until you can build up longer bouts of exercise and eventually cut down the rest a little bit. So if you're performing 5-minute bouts, you might want to do multiple bouts, like 3 bouts of 5 minutes, and then you might be doing that 3 times a day. So it all depends on what kind of exercise. But you want to give them a lot of exercise. I didn't say high intensity, but you want to give them a lot of exercise. They have endurance impairments. So give them lots of bouts. Have them get up, walk over to the TV, walk back, sit in their chair. Get up, walk over to the TV, come back, sit in their chair. What are they doing when they do that? They're doing sit to stands as well as walking. They get up, walk over, sit back down. So you want to do bouts of sit to stands and bouts of walking, and you can combine them by having them do multiple bouts of where they have to get up and go somewhere and then sit. Choose a mode that the patient enjoys. That's really important. And then as you develop progression, you want to develop duration first. Get them to do more and more and more and more and more bouts. until they can achieve a continuous exercise of 20 to 30 minutes. Interval training is the way to get there. Once they get to 20 to 30 minutes, then you can increase the intensity. Okay, they're working to a 5 out of 10 now. Have them work to a 6 or 7 out of 10. Okay, but don't increase them too fast. Don't increase more than 10% each week. Set up a progression for them to follow when you're not there, and use a log. Make them record their exercise so you know what they're doing and what their symptoms are. So what are interventions for poor endurance? You progress their activity to a moderate level with frequent bouts of exercise and rest, going up to a vital signs that you found were okay. Give them bouts for walking and bouts for any other exercise, and work to a certain level of dyspnea or perceived exertion, because they're not typically going to measure their heart rate. I'm going to tell you now that if your patient doesn't have a pulse ox, make sure you train them to learn what level of dyspnea is too much, where their SpO2 drops too much. But you should be bringing in a pulse ox when you're working with the patient. They're a lot cheaper now. They can get them for $20. These are something that patients should be having if they have oxygen saturation or desaturation with activity. So I highly recommend getting pulse oxes. What if they have decreased strength? The same thing. You want them to do frequent bouts of activity. So arm lifts, leg lifts, sit to stands are the best for the lower extremity. Frequent bouts of getting up and walking and then returning to sit. And teach these patients to work to a specific RPE or dyspnea. A lot of them don't have the pulse ox. Okay, we have a 52-year-old female. She's been in the ICU for 4 days. She's not been mobilized out of bed yet. The order is for out of bed. She has only had IVs and oxygen, nothing else invasive. So plan an out-of-bed treatment. How would you progress her out of bed? First, you want to see, can she tolerate sitting upright, standing upright, doing upper extremity activity, and walking? So assess all those different activities. Is she orthostatic? Does she desaturate with activity, etc.? What do you expect to find with this patient? Just what we said. Rapid heart rate rise, desaturation in SpO2, and we expect to also see poor endurance, very poor tolerance of activity. She may need some help. And how do you overcome upright position if she's orthostatic? You're going to have to do more frequent sitting upright. So sitting up in bed, sitting up edge of bed if she can. All these kinds of things to try and get her more used to the upright. In the beginning, if she can't get out of bed on her own and sit edge of bed, then have the nurses sit her up in bed frequently throughout the day. So have her sit in the sitting position frequently throughout the day instead of laying down. You want her upright as much as she can. And then you want to develop an exercise prescription for her for small bouts. So go from the bed to the chair and back to the bed and back to the chair and back to the bed and back to the chair. Frequent getting up and a little walking and then sitting down. And develop a specific exercise prescription for her. Okay, now she goes home and you're going to see her in outpatient PT, and you want to progress her back to her former activity. You want to get a baseline aerobic capacity, a 6-minute walk, a 2-minute step, something like that to see what she can do, a good outcome measure. Then based upon that, you want to set an intensity, you want to set bouts that she does it, and you want to work on not only aerobic, but you want to do sit to stands, and depending on what she did before, some upper extremity bouts. Okay, the MET levels she's going to start with are going to be 2 METs to 3 METs, very low level activities. Lots of bouts, but rests in between. And with her, she had COVID. What is her SpO2 response to activity? She may be limited if they don't supply her with oxygen. So check what her SpO2 response is with activity. Okay, you have a 64-year-old male, history of COPD, recently discharged from the hospital following admission for acute respiratory failure pneumonia. He was in the hospital 8 days, 4 on BiPAP. BiPAP is non-invasive ventilation, and he's discharged to home. So what do you think you're going to see with exercise with this patient? What's going to be your initial test? Personally, I'm going to get them up supine, assess that, sit, do ADL, stand, and walk. I'm going to see how they do all of that. I might do another outcome measure. They're going to be extremely weak, and they're discharging them fast to get them home, to get them out of the hospital where COVID is. So they want to get them home, and so you're going to test. They may not be able to do a lot. What do I expect to happen with this patient? I expect heart rate to rise fast. I expect respiratory rate to rise. I expect SpO2 to drop. I would expect that they have oxygen coming home, and if they don't, they need oxygen. Remember, we don't over-oxygenate at rest with a COPD, but we need to titrate their oxygen with their activity. So my exercise prescription is going to be based on how much did they drop and whether I can titrate oxygen. And I could teach my patient how to titrate the oxygen. They're going to need lots of frequent bouts. And there's a lot of literature that talks also about COPD, and prognosis is related to their quad strength. So they need to do lots of sit to stands as well as lots of frequent bouts of walking. So use some outcome measures to measure what they're like in the beginning, and then really work on both lower extremity as well as exercise. Now with COPD, you want them to be doing pursed lip breathing to help with their gas exchange. But they've also had acute respiratory failure, pneumonia, COVID, that's a restrictive disease. So you want to make sure they're taking deep breaths as well. The pursed lip is when they get too short of breath. That helps their COPD. Okay, we have a 60-year-old male on the ventilator for 10 days in the ICU for 14 days. He's discharged directly to home because the wife's healthy and able to take care of the patient, but the patient's extremely weak and can only transfer wheelchair to bed with a few steps in between. So home health has been ordered, and they also have a supplemental oxygen order. What are you going to do? What is this patient going to have for impairments? Endurance, breathing, diffusion, mobility, oxygen desaturation. So how are you going to assess exercise? Probably a 6-minute walk is way too much for them. I might use one of those mobility screens like the Johns Hopkins. I might use the SPPB for home. They may not be able to do a 6-minute walk very far. I mean, they may only be doing 5 feet, 6 feet, so they're not appropriate yet. You could do a 2-minute walk or a 3-minute walk. But I'm going to assess vital signs, and my bet is they're going to drop their SpO2, heart rate's going to rise, respiratory rate's going to rise. Okay, so this is going to be your typical patient that you see with this COVID. So they're going to need small bouts of exercise, lots of rest, but throughout the day. They can be doing these bouts throughout the day. Make sure they're not hypotensive with sitting up, all right? And be slowly progressing their bouts and their frequency of bouts, watching oxygen, watching breathing, and also working on strengthening, sit to stands, etc. So they have impairments, mobility, endurance, hypoxemia, increased work of breathing, and weakness. You want to optimize their oxygen with all their activities, short bouts, have them use that incentive spirometer they came home with for their breathing exercises, and particularly work on the chair rises. And always include education, self-management of their disease. So you're probably tired of hearing me talk, so now it's time for a summary. I'm sorry I took so long, but there was so much information I wanted to give you. I want you to understand it's very important to monitor vital signs with all patients and all activities. And so you want to determine what they want to do as well as what they're doing right now and assess these activities. Determine their limitations to exercise. Is it an endurance limitation? Is it an oxygen deficit? Is it a comorbidity? And develop a plan for overcoming their limitations for exercise. Very, very important. I want to thank you for listening and tolerating my talking for a long time. I want to thank the Cardiovascular and Pulmonary Section and the Academy of Acute Care Physical Therapy for providing this PACER program to all of you. I think it's very important for the knowledge to get out there. And I hope that this helped all of you. If you need further guidance, remember, you need to get help with a mentor or a consultant. But I do know there are many other PACER education programs coming down the line, and I know that there's more help for all of you. So I do hope that this helped you, and I want to thank the sections of the APTA for providing this free to all of you from us. And lastly, I'm just going to sum up with some education, with some references, and tell you, take a deep breath throughout this and make sure you take care of yourselves during all of this time. Thanks again.